Welcome, everyone, to another Wu University event, Orthokeratology 101. I am your host for this evening, Dr. Stephanie Wu, and I am the founder of Wu University. And it is now my pleasure to introduce our speaker for tonight. Dr. Thanh Mai is one of only 2 optometrists in Orange County with a fellowship of the Scleral Lens Society. Dr. Mai focuses primarily on specialty contact lenses. In particular, he works with patients suffering from corneal diseases such as keratoconus, pellucid and damaged corneas, and also lots of orthokeratology, and he has a huge passion for myopia management. Dr. Mai works at Insight Vision Center in Orange County, California. And Dr. Mai and I actually met at SCCO. We went to school together, and we were on the yearbook committee together for a year. So that's where I got to know Dr. Mai really, really well. And he is just, I think, so inspiring because he has taken a practice that really didn't fit any specialty lenses. And now that is basically all he does. And so he has been a very huge inspiration to many eye doctors who are looking to incorporate specialty lenses into practice and they really have no idea. So if you have any passion or desire to learn about specialty lenses and you have no idea where to start, Dr. Mai is totally your person. So welcome, Dr. Mai.
Wow, thank you very much. That was a great introduction. Yeah, I'm really excited to be speaking. Again, I'll be getting this later on, but yeah, I started a practice from scratch, and now I love going to work every day, just seeing patients doing specialty lenses. It's essentially all I do. So a few things, just a few financial disclosures, won't influence much of what we talk about. But I do want to mention something. I don't know if Stephanie saw this, but yes, Stephanie is my first business partner in optometry. So in 2000, this is a picture of us in 2008, 13 years ago. See, well, you'll notice a few things. See, Stephanie, she looks the same. So she has like a time machine. She's nothing has happened. Whereas me, like, things have definitely changed. I need IPL QID at this point to get to where Stephanie's at.
You look exactly the same.
But we actually made a yearbook together. We actually marketed it, did the production. We had a few $1,000s of revenue. We managed a staff. Ronnie, by the way, I ran to Ronnie at a conference at the GSLS in 2020. She looks the same. I was on an ad board with Brooke Messer here. She looks the same too. So it just goes to show you that if you do contact lenses and if you do myopia management, you can stay young a little bit longer. There's empirical evidence there. A little bit about me. I went to practice cold in 2015. This is a picture of us at our grand opening party. You can tell by all the Asian people there. I invited every person I knew in the family, and they showed up. And then this is a picture of me and the staff recently here. So, in 2015, we had obviously just one staff person working for us, a pre-optometry student. Now we have a staff of 20. And all I do is basically specialty contact lenses all day long. I don't do any primary care anymore. So let's chat about orthokeratology. That's why we're here. So I wanted to talk about the lens shape first. So this is a picture of an orthokeratology lens on top of a cornea and the fluorescein pattern down beneath. So I want to talk about a few things. The first thing is the base curve. The base curve in a orthokeratology lens is a reverse geometry, which means it's flatter than the cornea. So here would be essentially the base curve. Then there's the reverse curve, right? So the reverse curve is here, which is basically, it's called a reverse curve because it's a normal gas permeable lens would be relatively the same curvature as the cornea, but it's reversed because it's actually going to be steeper in this area than the cornea. And then we have the alignment curve, where the lens basically tangent to the cornea, lens softly there, and then you have the peripheral curve here at the very last part of it, where you get that little bit of green at the very end. In general, how orthokeratology works is that the central base curve is flatter than the cornea. So let's say you have a 43 cornea the base curve might be like 40 if you're trying to flatten by 3 diopters or so. It's a closed system. So how it works is this area is going to create a seal here where it lands at the alignment curve, which causes a sort of a negative suction force. So what happens is the cells migrate out in and in to out there to fill this space here. That's essentially what orthokeratology does. The goal is actually for it not to bear very much on the cornea. If there's a lot of corneal bearing, you might get SPK. The goal is actually just to create this negative suction by making a closed system, and the cells migrate here by a suctional force. I don't like to think orthokeratology smushes on the central cornea very much, more that it just creates this suctional force to pull away from the in the periphery. How it looks next is like this here. So this is what happens to the cornea afterwards. So when you have a lens like this and the cells migrate from in, out, and out, in, you get a flatter cornea centrally. So let's say this is an example of a patient who is a -5 prescription. There's actually one of my texts that works for me. And what happens is the central cornea gets flatter by about 5 diopters. And then what happens here is in the red wing, it gets steeper there by about 5 diopters than the original cornea. So if you look at it this way, it kind of matches 1-to-1 with the Fluorescein pattern. So here would be, in the blue outside here, would be essentially this alignment curve right here, where the steeper red part is, would correspond to the green color here. So you're wondering where the topography, how it matches the Fluorescein patterns like that. And then the center part is where the base curve is, and it'd be the middle here. What happens is that if this is a -5, you get like a -5 in the middle in terms of treatment. And here you might get like a +5, which you can actually do by getting a difference map and clicking on this part of the difference map, and it'll actually tell you the difference between your topography afterwards, after doing orthokeratology, versus the original cornea, and you actually see that it's a -5 +5 if you click on it. What happens is when it's -5 in the middle, is you'll have the treatment basically hit the macula, but when it's +5 here in the peripheral cornea, that's where it'll land in front of the retina. So this is an eyeball, light's coming in this way. Light going through the middle might land here, but light hitting the peripheral cornea might land in front of the retina. So, and it's that peripheral defocus that gets you that myopia management. By the way, I used to do a lot of SAT tutoring, and I always think that PowerPoint presentations are a really boring way to learn. People actually don't learn that way. So if you see me doing a lot of whiteboarding and drawing, it's because it's my background doing SAT tutoring. Okay, so that's a little bit of that. Some background in terms of topography and lens shape. In terms of your ideal candidate, what I find is that the most common, the ideal candidate that I find in terms of lifestyle is myopic children. And the main reason that drives it, and you'll find this if you talk to a lot of orthopedic practitioners, the majority of our patients ends up being myopia management patients, and they're children who have myopic progression. That's at least 80% of what I do. The other 20% are definitely adults. I do hyperopic orthokeratology as well, and plenty of adults, and I've done everything, but still the majority is myopic patients. That's your ideal candidate. As far as prescriptions to watch out for, once you get really good, you can do honestly anything. You can do a -10, you can do a +3, you can do 3 diopters a cylinder, but I wouldn't do that starting off, especially if you're doing just a few first cases. And this is Orthokeratology 101 for those just getting started. I would aim for these patients that are low myopes. -1 to -6 is a good range. With the rule is easier than against the rule. Astigmatism. K value is 40 to 46, though we'll talk about later on the eccentricity is more important than the K value. And then the eccentricity, which is the rate of flattening, 0.3 to 0.7. These are just kind of general guidelines. So if you do a consultation and you're like telling a patient, you're a good candidate, I think, keep these things in mind. And if they hit all these criteria, they're probably a good candidate. Outside of that, you can probably still do it. Honestly, once you get real good, but these are the slam dunk cases. In general, the base curve, That's responsible for central flattening. In orthokeratology, it's going to be flatter than the original cornea. The reverse curve is steeper than the original cornea. That creates that area where the cells suck into. The alignment curve is similar to the curve of the cornea. It's where the lens is supposed to gently land on the eye. And then the peripheral curve is for tear exchange. Poor candidates would be people who have really high astigmatism, weird oblique axes, really flat or large corneas, crazy unrealistic expectations. That's why kids do so well, is because they are very easy. They don't have unrealistic expectations. Because with orthokeratology, sometimes you have days where it can fluctuate. If there are mismatches in the refractive cylinder and the corneal cylinder due to, let's say, internal astigmatism, poor candidate as well. Of course, there's also these absolute contraindications. You would never do it on a patient with keratoconus. This is a patient with keratoconus with intacts, keratoconus, corneal transplants. Post-LASIK is a, have I done post-LASIK? I've done 1 or 2 only because they really wanted me to do it. And did it go well? Yeah, it actually went really well, but I don't recommend it. It's hard to do, and I don't think I'll do any going forward, actually. I just want to do a couple, but I don't recommend it. So the contraindications would be keratoconus, of course, corneal transplants, any strange diseases, active corneal infections, inflammation of the anterior chamber, very severe dry eyes, any condition that is made worse by contact lens wear. You want to just avoid those ones, because you don't have to do orthokeratology. Even for myopia management, you could just do atropine instead, for instance. Know that when you do your topographies, it's really important how you measure things. And so this is an example. If you're doing, most of us probably have placido-based topographies. This is an example of the same patient just taking repeat topographies on them. And so by taking it again and make sure you get a quality image, that can definitely influence your outcome. And the most important topography you ever take on a patient is the first one. The baseline topography is the most important one. I recommend having patients, if they're really dry, you can even have them use a little bit of Cyclovist beforehand. I would have the patients pull down the lower lid and you pull up the upper lid so you can get a really wide capture. Again, orthokeratology lands more so in the peripheral cornea than the center. And so you want to get good data in the peripheral cornea so you can design a good lens. In general, apical astigmatism, which is astigmatism that is in the central cornea, is easier than limbus to limbus. Limbus to limbus means that the astigmatism kind of goes all the way from one end to the other. Now, can you do it? Yes. I do it all the time. I actually think limbus to limbus is a piece of cake now, and I jump into it head first, no problem. Especially nowadays, a lot of lenses you can design toric lenses, and so I wouldn't be as scared today as you used to be. I would hear lectures more like 5-10 years ago that was more scared of doing limbo to limbo, but now I think everyone can just dive on in, because you can do toric lenses. Know that when you're analyzing maps. And by the way, I'm going to jump through these slides because I have a whole bunch and I only have 15 minutes. And English was my second language. So sorry if I talk too fast, you can't understand me. But anyways, this is an example of a tangential map versus an axial map. I like to look at the tangential maps first, because that tells you exactly how the cornea is shaped and exactly how the orthokeratology lens is fitting. The axial maps are okay. They kind of smooths the data over. It's okay to use for checking power changes, but for the most part, when you're analyzing maps and comparing them, the difference maps, you want to use the tangential map. Some corneal topography basics. So, because you need to know some topography basics if you're going to do orthokeratology. Know that prolate is what we talk about when we talk about a normal cornea. An oblate one would be flatter centrally, like this one over here, and steeper peripherally. That'd be your patient has orthokeratology or LASIK. In general, the prolate eccentricity, and eccentricity is the rate of flattening, we would say it's 0 to 1 for prolate, and oblate would be less than 0. A good mnemonic is that know that prolate, the man upstairs is a pro at making corneas. And so it's prolate when you're the way you were born. Quick lesson on corneal eccentricity. So eccentricity, a little bit of confusing topics. So I'll dive into this a little bit more. But basically, eccentricity is the rate of corneal flattening from the center to the periphery. Okay, so I'll give you an example. These are two corners here that I took in the office, and the K values are, relatively not too, like the average K for both of them is in the 45s. So the K values are not too different, but the corners look way different because one has a much higher eccentricity. It flattens quicker. See this one here in the top upper left? This one is, 45, but it rapidly flattens quickly right here and becomes blue very fast. That's why the eccentricity is 0.82 in the flat E and then 6.8 in the steep. Now, whereas this one here, see how it's basically, even though as I move out from the center, it's still green. It's not blue yet. It hasn't flattened as quickly. So the eccentricity is lower. And so the eccentricity is, again, it matters so much because the lens for orthokeratology lands in the periphery more than the center. And so know that as the eccentricity increases, you should have greater corneal. As eccentricity increases, the corneal sag decreases, and vice versa. As eccentricity decreases, the corneal sag will increase. So that affects the sagittal depth of the lens you need to use to fit it properly. So I want to show you some examples, hopefully to hammer this home. So I've got another whiteboard for you guys because I love whiteboards. This is an example here of 3 different eccentricities. So this is the same K value. So it looks in the upper left. Let's say this K is like a 43. It's a 43K in the center here, right? But all of these have different eccentricities. 0.7 would look like this. 0.5 would be in the middle. 0.3, I'm exaggerating, would look almost catatonic, but not really. But basically it'd be steeper, right? So I'll give you an example. If you're doing orthokeratology, let's say you have a 43 diopter, okay, and let's say you want to flatten it 4 diopters. This is patients. Let's make it round. Let's make it 3 actually. So let's say your base curve of the lens is 40. That's the base curve. So your base curve is 40. You're good here. And let's assume that you're making a lens that overestimated the eccentricity. Basically, when you were designing your lens, you thought that you had a 0.7 eccentricity corner, but you actually had a 0.5. What that would look like is this. It's coming up, I'm going to exaggerate, it's going to come down. Instead of hitting the cornea there, it's going to not quite land and make it. So it's going to come up and up, and the same thing over here, not quite make it. So in this situation, you have a 0.7 assumed lens. When you have a 0.7 assumed lens, the lens you made flattened too quickly than the actual cornea. What happens is you're going to get insufficient seal here, insufficient seal here. We'll call that lens loose, or AKA flat, or AKA too little sag. So what the fix with this would be to actually bring this lens down. You would steepen it down. You would bring it down to fix it. So that would be what would happen if you had a lens that was too flat. Now let's imagine another scenario here. So this is the same thing, 43, 40 base curve. You're aiming for -3. -3, my writing's terrible. And again, you have a 0.5 eccentricity cornea, right? Now let's say you thought that you had a 0.3. You designed a lens that was 0.3. So how that would look is the lens that you'd make would land here real strong, and then it's going to just be real high and then be like this, probably where the lens would be too steep because you underestimated the eccentricity. So this is a 0.3 eccentricity assumed lens. So what happens is you would have essentially a central island would probably happen. You would have basically a lens that's we call that too tight. For the most part, in simple terms, know that lenses are either too tight or too flat, AKA too steep. People say steep, flat, tight, loose, or too much sag. Okay, now how would you fix this one? In this situation, you'd probably want to chop the reverse curve or flatten out the landing alignment curve a little bit more. And so you want to bring the lens back down to get to your ideal orthokeratology lens, which would look like a nice landing here, come up barely like that, right? The goal would be to head this way. So that's basically why eccentricity is so important. All these corneas here have the exact same Ks in the middle. But what matters and what will affect your fit so much is the eccentricity and the lens saturated depth in the periphery. Know that most of the time for the base curve of the lens, you actually probably rarely change that. Most of the art and science of orthokeratology rarely involves flattening, steepening or flattening the base curve as much. I'd say maybe that's 10% or less of your time. The majority of the time when you're troubleshooting orthokeratology, basically when things go bad, it usually has to do with your reverse curve or your alignment curve. And that's like 90% of it. The base curve is mostly to change the RX. This is how much you're targeting. Is it, 43 or 40 to 43? Or am I trying to get to 38? Because I'm trying to get 7 diopters. That's for the RX. But afterwards, everything else, 9% of what happens and goes wrong is that your target's fine. Just the way the lens is sitting is not fine. And so you adjust either the reverse curve by making it steeper or flatter, or the alignment curve steeper or flatter. It's one of those combinations. You either make the reverse curve steeper or flatter or the same, or the alignment curve steeper or flatter or the same, and you can fix almost anything. In general, as you are doing orthokeratology, I like to have a really nice, clean baseline topography, because again, that baseline topography is the most important one. You never have a chance again to really get a cornea that's completely the same once you start doing orthokeratology. Here's an example of why it matters that a patient comes in without wearing any contact lenses, even soft contact lenses. I don't want them to have before a consultation, because I want to see the baseline topography be completely untouched cornea. Here's an example of the same patient up above. This on the left, they came in without wearing an RGP. And the right, you notice that they are wearing an RGP. You can just tell by looking at that the lens is kind of more flattened over here, and that the cornea is a different shape. And that's because they'd worn RGP. It changed the eccentricity, it changes the shape. A more exaggerated example is the bottom left. This is an example of one of my keratoconus patients. They came in wearing an RGP, and I said, stop wearing RGP and come back. And for a week, no, I said for 2 days. You don't need to do it for too long. And then I did a topography again. And then this was the topography without them wearing the lenses out for, in this case, 24 hours. Ignore the little central blue thing. I think that's just aberration. The main thing is, the take-home message is that by wearing RGPs, it can reshape the cornea. You have a molding effect, and that can influence the lens design dramatically. And with orthokeratology, sometimes that changes, the change you're making are literally like 10 microns. I'll change the reverse curve by 10 microns, 15 microns, and that's like a big difference. In general, this is what happens after orthokeratology. So on the topography on the left is just a normal pre-treatment cornea. Nothing has happened. On the right, it's a perfect example of perfect treatment. Nice centered treatment, nice red ring, bullseye, no looseness. Patient was a -5. They were plano in actually 1 day. And by the way, when this happens, what I like to do is I've done this before with patients, because I love showing off. Sometimes I would just like pat myself on the back. And patients, by the way, we've done studies and we've done focus groups, and we've learned that patients actually, one of the top criteria for a doctor is confidence. They will trust a doctor with confidence. That is one of their top criteria in terms of what makes them feel good going to a doctor. So have high confidence, pat yourself on the back when you do it right. The picture on the right is a subtractive map. So this is the first pre-treatment topography. This is the topography afterwards. The difference map is what matters in terms of what has happened to the cornea afterwards. So when you're working with your labs, they're going to need to see a difference map, because it tells you where the lens was actually landing and what's going on. In this situation, that obviously it matches the post-Ortho-K topography where you have the central flattening. You can click on this. You'd find if you're treating 5 diopters, you'd click on the middle and you'd find it's 5 diopters different. Here you'd see 5 diopters steeper, for instance. Here you'd see it flatter as well. Here you technically see in the periphery, it's a little bit steeper. So maybe the lens was actually a little bit steeper in the periphery. Maybe we should, if we had to fix something, we might flatten the alignment curve a little bit. in general, know that when you're doing orthokeratology, think of it like, we know that classically a minus lens looks like this, and a plus lens looks like this, right? So let's say this is a normal cornea looking. Look, this guy's looking over here. With orthokeratology, you're going to flatten the center and then steepen. So you're gonna flatten the center, but you're gonna steepen the peripheral cornea. So basically, what happens if at a side view is you're going to. I'm exaggerating, but this is the this is the cornea after Ortho-K, basically. Oh God, that was terrible. Hold on. I'm just gonna Pac-Man it. Essentially, what you're doing is you're making a minus lens on the cornea, and so that minus lens is essentially what you're doing with orthokeratology. You're making a concave surface on the eye in a way compared to the original cornea. And this is my huge exaggeration, but that's exactly what you're doing. Know that sometimes when you're doing orthokeratology, that this is an example of -5, but sometimes I talk to a bunch of colleagues. I've taught dozens and dozens, maybe over 100 doctors at this point how to do orthokeratology. Know that when you get the map, sometimes they don't look clean. Like this nice red wing, I've had my students say, it doesn't look clean. I don't know what's going on. Sometimes it's not clean. And a lot of that has to do with also even just how much you're treating. So for instance, this is a -250 patient. This person is seeing 20/20, by the way. It's perfect treatment. Patient's happy. Everyone's high-fiving each other. But obviously, you don't get that nice red wing on this one because you have just less tissue to move. If you're doing like a -1, sometimes you can barely see any difference at all. But the patient's going to be 20/20 and happy and planar or fraction. So know that you don't always get those clean red wings. It's totally fine. But orthokeratology consult itself, when the patient walks in, I like to just take unaided visual acuities, take a manifest refraction, slit lamp, of course, if you will, any pathology. Very important to take corneal topography and HVID. Don't be those doctors that try to do orthokeratology with just a keratometer. Again, the central cornea doesn't matter that much when you're fitting orthokeratology. It's how the lens lands in the periphery, right? That's 90% of problems or more happen because the reverse curve or alignment curve are off. And so you need to have a corneal topography. For myopia management, you need to take axial length, and I'd recommend a wet refraction with either tropicamide or cyclopentalates. I'm a big proponent of not dabbling. If you're gonna do it, do it. In my opinion, if you're gonna be world class, otherwise I would refer it out. But I believe axial length should be required. When you're fitting the lens, if you're doing empirical fitting, it's really easy. And this is the way I do mine. But basically, for the most part, prescription, K-virus, HVID, take up topography, email it to the lab, they can design a lens for you. It's seriously that easy. You don't need to be a genius. Let the lab do the work. If you want to do some of the work yourself, though, and I used to do this when I was at SECO, is that you can have a fit set, and then you pick a lens based on like a nomogram ruler, and you fit it and you check it, and then you can troubleshoot on the spot. Which could save you time in the long run as well, but I just choose to do empirical fitting. For the dispense, I like to take entering visual acuities, of course, slit lamp. This is something that I definitely do, highly recommend it. I would recommend doing Fluorescein before applying the lens, just the first time, not chronically, not at follow-up visits. I wouldn't hand them drops to take home, anything like that. But just for the very first time, it just makes everyone's life easier. Trust me, do it. Then you put on both lenses, add Fluorescein, do an over refraction to check, make sure you don't get too much plus. It should be every manufacturer's difference, but usually plano to +50 is usually the target. Check Fluorescein patterns. I like to wait at least a minute after checking Fluorescein pattern. I get these videos from my students. They'll paint the eye with a whole bunch of Fluorescein, and then they'll take a video and then they'll send it to me. But I can barely see anything. I said, "How long did you wait?" They said, "I took the video right afterwards." I said, "No, wait at least a minute, because the Fluorescein will look different after you wait, and the pattern will actually show through." I recommend taking photos of the patterns. It'll help you to troubleshoot and send it to the lab. I call for a technician to do the training. I recommend celluvisc right before they go to bed. So they put a little drop of celluvisc and they put the lens on. It helps the lens seal better. There's no preservatives in it, so I'm happier overnight. And in the morning, if they feel a little bit dry, they can use Refresh Plus. That's usually what I do. I got some examples here of how the fluorescein pattern might look. So let's chat about it. So if you look at this one here, you might notice a few things. I like to check, first of all, how the lens is centered first. So if you look at how the lens is centered, you might notice this one here. If you see the pupil here and you see where the reverse curve is, and you can see where the cornea is on the bottom of the lens is a little bit high. So I would say this is superior decentered. Okay. This one here is perfect, right in the middle. And this one here is not too bad. This one's actually pretty centered as well. We'll talk about what's wrong with this one later. As far as fluorescein pattern is concerned, how would this look? I did a little cross section here. See this little line right there? That's a little cross section. Let's pretend I'm gonna do a cross section and show you how it looks on the lens and the cornea. So basically, it might look like, I'm exaggerating. Wait, hold on. I don't like the way that lens that looks. We'll delete that. So basically, it might look more like this, up, and then pretty good, and then pretty good there. Okay, so what did I just do? If you didn't notice what I did, essentially what I did was, if you look here, you see how there's a little bit of green here? So I'm looking at this band here where the alignment curve is supposed to be, and ideally it's supposed to be black, like this one. See how it's kind of black? Here it's a little bit green there. So I would say there's a little bit of green left over here, and there's a lot of green here. Not a lot of green in the middle. So I'd say there's green here. So this lens is probably a touch loose. When a lens is a touch loose, because you get a little bit of green here. See a little green right there? When you get a little bit of green there and the lens is loose, sometimes a loose lens or a flat lens will decenter superiorly. Whereas on this guy here, this lens here, the ideal lens, it's going to land perfectly right here. It's going to come up. It's going to come down, come up and down and be perfect. Basically, this section here corresponds to this section here. This section here corresponds to this guy right here. And then this guy right here corresponds to the center right here, right? So this one's ideal, win-win. Everyone's happy. This one here on the right, you notice that it lands really strong. You see that black band? So when I look at orthokeratology lenses, by the way, I look outside in, because I'm more interested in how the lens lands first. That's just the way I think. And so so here it's landing okay all the way around. So if I were to bring it down, if I were to bring this part down here, I'd say, hey, lands good, lands good. And over here, if I were to bring this down, I'd be like, oh, lands good. Now, where it's not good is here. See how there's basically no black in the middle, like the bullseye pattern is gone. It's like still green, even in the center where it's not supposed to be. So I'm going to exaggerate. The lens is basically like this. It's like almost getting there, but not quite. Lens is too high. So this is basically poor treatment zone. Poor treatment zone. Lens is too tall, aka too tight. So this one here, this one was too flat. This one's too tight. And so you have a bunch of green everywhere, even in the middle. You didn't want green in the middle, but you got it. Now you have no black on the sides. Sorry, no green on the sides, so it's all black there, so it's all good. And so whereas here it leaked out, so here you're tight, but then the center is just too high, definitely too tight in the middle. Lens is too tight. A few other examples of fluorescein patterns. This one here, you notice that the lens is decentered inferiorly. So this is inferior decentration. Usually to fix this, you might flatten the lens to bring it up. So you'd flatten the reverse curve, the alignment curve. Usually I like to flatten the alignment curve. In this situation here, this one's fine. This is ideal. Again, this one's perfect. Change nothing. And this one, hard to tell, but you see here, it's kind of coming over the limbus right there. So this lens is decentered this way. So this is laterally decentered. And usually the fix for lateral decentration is my favorite is just to increase the overall diameter of the lens. Overall diameter of the lens, or you can steepen the lens at the reverse curve or alignment curve. But I like to, if you have room, make sure the lens not too big, but increasing the overall diameter is very helpful for that. in general, you're going to find that if you're fitting patients that have toricity, which I love doing, I'm not afraid of astigmatism whatsoever. This is an example of a patient who has with the rule astigmatism. So this is with the rule. What does with the rule mean? With the rule means they're flatter side to side and steeper up and down, right? That's with the rule. And so I'll give you an example. So if I were to do a horizontal cut through here, lens is actually landing pretty good. So lens is landing here, comes up, comes down. No, I went too far. And then up, pretty good. No problem, right? Now here, if I do a cross section up and down, you see how it's green still there. So we have that same issue where it's too loose. So the lens is coming up. Center's okay. Actually, maybe the center's not okay. It might be bearing on the cornea, right? It might be too much black there. But again, what you're seeing is that to match, you see how here corresponds to here. So it's still green. So lens is loose there. And the difference, what do you do about it, right? So lens is side to side fine. Don't change the side to side if it's fine. So you would want to change it up and down vertically, ideally only vertically. And so the fix for that would be a toric lens. And so what you would do is you'd say, hi lab, make me a toric lens, leave the sides alone, tuck in the top and bottom so that this lens comes down like this. Bring it down for me. And then that will get rid of this green stuff. It will become black, right? We want it black instead of this green here. So that's what you do. So get a toric lens for this situation. I like cellular again. It helps relieve dryness and helps to fit better. Honestly, kind of sometimes cellular can kind of reduce a little bit of your sins because it just makes everything look good. I like to use hydrogen peroxide every day. If you're getting clear care, avoid hydroglide. Just get regular clear care or use something else. I use, and I think other people use like the Refine One Step, Aqua Clear, things like that. A lot of times these patients will actually complain if you just gave them clear care. I've learned this doing over 1,000 cases, is that sometimes the clear care is supposed to neutralize in 6 hours, but it kind of doesn't. Like some residues stay behind in like the reverse curve. The patients put it on and it burns. And so I like to tell patients that happens, rinse it off beforehand. And then that can help out a lot. I have patients remove it with a DMV remover it's just easy to take the lenses out with a little DMV. You can teach them with the eyelids afterwards, but I would start there first. This has nothing to do with anything, but this is my daughter, Kinsey. She's 9 months old, and she's going to be a koala bear for Halloween. I'm going to be a eucalyptus tree, and so I'm going to hug her. And so she's like climbing a eucalyptus tree, and we're going to take a bunch of pictures and send to grandma, and grandma's going to die because she's so cute. I see the patient back for a one-day follow-up, and I'll tell the patients that, I like to tell patients, I'm happy if I get half the prescription the one day. And what I do is I like to show them the unaided visual acuities after the one day, because honestly, almost every time I do better than just half. And so it's awesome when the patient's 2200, the next day they're 20/20. We're just high-fiving everyone, and the patient's telling me I need to refer 10 of my friends to you right away, and I'm like, yes, do that. Expect a messy topography. It's not going to look clean. It's only one day. I always reassure the patients if they're a little bit uncorrected that we're heading in the right direction. I like to give loaner glasses if their patient is, in the middle of treatment. So let's say at the one-day follow-up, this patient is still like a -3 because they used to be a -6. I don't like to give, if I can, I will if I have to, but I try not to give too many temporary soft contact lenses, just because, then the patient's wearing a soft contact lens wearing a hard lens at nighttime, and then they wake up with a soft lens all day long. They're basically in a lens 24 hours a day. I'm like, yeah, I don't even like that. We have these loaner glasses we edge in office, and we have a bunch of -2s, 3s, 4s, and we just give them to patients to tide them over for 1 or 2 nights. And I like to do that. Some examples of troubleshooting things gone wrong. Again, this is an example of lens is decentered a little bit up. The lens is decentered superiorly, and also the treatment even is not that strong. You can see kind of the green here doesn't land very strong. So this indicates the lens running too high, the lens probably too flat. To fix that, I steepen the lens in this situation at the reverse curve, but you can also do it at the alignment curve. And you'll see here now that here, it's just a little less green here in the bottom. See that? It's like less green, more blue, less green, more blue here at top as well. The red wing is stronger because we're getting better treatment. So again, as an example of how to fix a lens that is too loose. If a lens is too low, I like to flatten the lens. So in this example here, you have pretty bad central treatment because the lens is too tall. And lens is also low. So it's inferiorly decentered. So there's two things that tell you you should flatten the lens. The lens is too low, center treatment is really bad. So I flatten the lens situation. In this situation, I also increase the overall diameter. And I got this now, nice, better central treatment in the middle and better ring. Everyone's happier. Lateral decentration. This will cause a lot of unwanted undercorrection, astigmatism, distortion in your vision. The best thing I like to do is increase the overall diameter and fix it there. This lens is, you can see how it's digging in right here, and it's decentered nasally. So the lens is too tight in the temporal side, probably too loose on the nasal side. You can also even loosen this side, steepen this side, and then also increase the overall diameter. You'll probably center better. If the lens is really tight, sometimes you can get air bubbles underneath it. And so this is an example of the reverse curve is too tall, and that's why you're getting this air bubble. Of course, check, make sure it is that way. You can add more fluorescein. You can move the lens around, see if it fills up. But if you get a huge bubble, sometimes the lens is too tall and you want to just flatten the reverse curve there. When to consider toric orthokeratology lenses. In general, if you look at the 8mm chord, if there's more than 30 microns of elevation differences in the principal meridians, that's when you should think about toric orthokeratology. Remember, it's not about the keratometry values as much as it is the difference in the elevation at the 8mm chord of the principal meridian. So just use your topographer, click on that part, and let's say it has 40 there. 4,000 there, and the other one's just 30 microns more, then consider a toric lens. Dimple veiling, I see this sometimes actually. It can happen. Usually the lens is too tight. So you need to just flatten the lens out. Sometimes it can just go away on its own. So you don't need to change very much, just kind of monitor it. Lens sometimes can bind and get a little tight. And so if it's hard to remove, I like to have the patients use a little bit of artificial tears right before they take the lens out and kind of just try to break suction with their eyelids. If not, I say we can redesign the lens. You can make the lens edge a little bit thicker maybe, or you can loosen the peripheral curves. But usually, honestly, most of the time, just by having them wet their eyes and break suction with their eyelids, that's usually enough. I like to keep track of the lenses I'm giving. So I like to call it Ortho-K R1, L1, R2, or L2, and make the little notes about what I did different. So I said R2 is, I increased the sag at the reverse curve by 15 microns. And that's kind of how I keep track of it. In general, this is how a lens should look ideally, right? So this is the red's base curve, the green is, the blue is the reverse curve, the pink is the landing curve. This is an example of a perfect fit. What can go wrong most of the time is these 6 situations down below encompass most of what can go wrong. Essentially, the lens is too loose here. So if you can find out which one went wrong with your case, you can fix it almost every time. You just have to find out which one of these 6 problems on the bottom that probably encompasses 95% of things that could go wrong, which one it is. If you do, you're gonna do just fine. So in this situation, the lens is too loose. I'm gonna increase the sag at the blue or pink. This one here, the landing is good, but the reverse curve is too tall, so the lens is too high. This one here, the reverse curve is good. Alignment curve is too flat. I would steepen it here. This one, alignment curve is too flat, and the reverse curve is too tall. This one here, too steep at the alignment curve. Reverse curve might be okay. This one here, again, too steep at the too steep at the alignment curve, or I might want to steepen the reverse curve. So here's a quick little case, and I think we're almost near the end here. Example is a -4 patient, -1 axis 160. Basically, got it pretty good with the first lens, but I got a little bit of width the wall astigmatism left over. So I wanted to clean that up. So how do I clean that up? You see how there's a little bit of green here, a little green here, a little bit of green here. So the lens is still a little bit loose up and down. So I would say, okay, well, I'm looking at the difference map. So on the right, it's the difference map. That's the most important part. So I look at the difference map. Okay, yeah, look, I'm looking here at it's a nice difference here. It's landing right there. It was blue there, blue spot here. Up and down there, I see a little bit red here, still red right there. So I would say, hey, looking here, it's probably number 3 or maybe number 6, vertically at least. Horizontally, it's fine. That's why you've still a little bit of with the wall cylinder left over. Vertically, it was not treated as much. And so you need to have more treatment vertically to add more minus power, right? So I'm thinking, okay, I'm going to basically steepen the lens. What I did in this situation was I thought it was this scenario here. So I'm going to, in this situation, I steepened the blue and I flattened the pink to bring the lens down to land here to the ideal fit. And then we got it basically patient. Now, you notice how the green color on the topography kind of went away up and down. See that? Now it's kind of blue. So all I did was change the vertical meridian, by the way. I made a quadrant specific change up and down only. I didn't change anything side to side. And I left the side sides alone. And then the lens now centers better. And also the treatment is better as well. Patients, all the astigmatism is gone. Patient is plano. In general, for myopia management, you want smaller treatment zones. So the treatment zone for myopia management, remember, the point of myopia management is not to flatten the central cornea. The reason to do myopia management orthokeratology is actually to steepen the cornea. That's what you actually care about. The vision is the side benefit of doing myopia management, actually. So you actually want to make sure this steeper part, the red, is within the pupil, so you get that peripheral defocus. So the goal, that's the treatment zone. It includes, for myopia management, that red ring. For adults on the right here, I designed a lens that was larger. I maxed out the base curve. I made a really wide optic zone, and then just a real thin reverse curve. And so for a patient, you wouldn't care about myopia management. You'd want to just have all that red ring outside the pupil. Checking for myopia progression, of course, the best way is axial length. My goal for axial length is my ideal goal is less than 0.1 millimeters per year is perfect. But ultimately though, anything more than 0.2 millimeters a year, and I usually check every 3 months, that's a little bit too fast. So I'm checking those rates. If you don't have axial length, what you can do is, and you don't want patients to wash out of orthokeratology, you can have them put on the lens and do a over refraction. If you get more minus, that can indicate myopic progression. Granted, there should be, if in the absence of lens warpage. This is my son, Jackson. I'm taking an axial length measurement of him. He's not orthokeratology, just a picture of me doing axial length on him, because I'm a 27 millimeter eye. I'm a -9. So to me, this is real, and I got to help out my son, Jackson. His eyes are actually 23.96. And he used to be, and we want 22 millimeters at that age. And he was a plus 0.75, and now he's a plano, and he's 5. So I'm treating with atropine already, even though he's not myopic by classical standards. To me, he's myopic because the axial length is larger than he needs to be. The clear study shows that plano refraction at age 5 is basically destined for myopia. So we're doing 0.025% atropine in him right now. I'll check his axial length again in a few weeks. I'll let you know how he does. Otherwise, that's the end of my lecture. Thank you very much for listening. Hope this was good. Hope you liked it. Thank you. My email address is drmy@insightvisionoc.com. Send any questions, comments if you like. But if you have questions about how your fit's going, email the lab. I get too many emails about how to fix this fit. So yeah, that's that. And besides that, I'll let it over to Dr. Stephanie Wu and Q&A.
Awesome. That was great. I loved the smart board and drawing the different things. That was super helpful. I think lots of people found that very valuable. So thank you for making it a little bit more interesting than just slides. That was really awesome. And just to anybody listening in, if you loved Dr. Mai, he is actually talking again on Monday about how to build an orthokeratology practice from scratch. And he's also going to be talking about our real life orthokeratology. It's a Sunday long meeting, and he's going to be talking about how to explain myopia management to parents so that they understand. And I am thrilled to learn about this because this is such an important topic. So let's go through a few questions from Dr. Mack. She wants to know, is it possible to do CRT for patients with coloboma?
Wow, good question. I've never done it. I'd say if the cornea looks fine and there's no issues in the front surface, Yeah, I don't see a reason why they can't wear contact lenses. Because it's on the iris. So, Dr. Wu, anything about that? Have you seen a coloboma, done orthokeratology? But I don't see any reason why you couldn't.
I mean, I guess it would depend on what the vision goals were. So if it was like an iris coloboma, which I'm assuming,
Yeah, that's what I'm assuming.
Talked about,
Yeah.
You know, is it, are they having issues as far as glare, photophobia, things like that? Is if the main reason for them coming in was because they were trying to solve that problem, then obviously that would might go toward like a prosthetic contact lens issue. But if they don't have any issues and they're wearing glasses or contacts just fine, and like you said, if the cornea, no problems there as far as, it's pretty normal, I don't see why you couldn't do it. Yeah, great. Next question, Dr. Diffendahl wants to know why clear care without Hydroglide.
Yeah, sometimes Hydroglide can leave like a little weird layer of film on the lens. And so I prefer without it.
And I also feel like a lot of patients they respond to it kind of strangely, and myself included. I tried clear care with Hydroglide and I wear soft contacts, and it kind of like made my lenses feel strange the next day. So I don't know what it is, but I totally agree with you with that. I would recommend that as well. Dr. Craddock wants to know, which topographer do you recommend?
The one that most orthokeratology doctors kind of swear by, and is the Medmont. And then to me, that it's the Medmont or Oculus. Those are kind of the winners right now in the Ortho-K community. They're both great. I hope I don't get in trouble saying that. Is the C portion over? But anyways, yeah, those are the ones that other doctors and I would recommend.
Great. Dr. Pillai wants to know, have you found issues with adhesion using a thick drop for insertion at night like Celluvis compared to a thinner drop like a preservative-free Opti?
Good question. I've not seen any difference. I've done both. I've done I've done Refresh Plus, Celluvis, Optase, a bunch of stuff. But yeah, I just, it works really well. It cushions it. I feel like it just feels better. So I stick with Refresh Celluvis because I like the fact that it's all preservative free and single use.
Yeah, love it. Dr. Sanders wants to know, if you have a soft contact lens where if they need to stay out of lenses for their baseline topography, how long are you having soft contact lens wearers out of their lenses before you're doing that baseline topography?
I'm fine with just 24 hours, just like one day, basically. Yeah.
Great.
Soft lenses don't do too much. But again, the first topography, I think I learned from Randy Kojima. He's like, the baseline topography is the most important topography, and you don't get another crack at it. So make sure it's good.
Excellent. Next question is, how do we know how much numerically to flatten or steepen when we need to make adjustments to the lens?
Good question. Yeah, it depends on how much things are off by. So let's say you're off by like a diopter, you might want to flatten the reverse curve more. Like, I kind of say medium changes in my system is like small to medium changes in the reverse curve would be like 7 to 10 microns. If it's like things are way off, 15 microns of the reverse curve, and 20 if it's like really bad. But basically, it's kind of, I would talk to your lab because every lens design is different. So this doesn't apply to the lens design you're going to use. But yeah, usually there is a amount of steepness and flatness that corresponds to what you're seeing on the topography and how much the undercorrection is. And undercorrection is usually what you're trying to fix.
Great. Next question, how do you interpret axial length progression versus physiological growth?
Yes. So the eyes are supposed to grow. And so naturally, even, with no problems in a way. So my cutoff is about 0.2 millimeters per year in general. Now, the age matters, but the age that we usually work with is at all practice, usually ages 6 to 13 is like the hot spot. And so usually more than 0.2 in general is too fast. And my goal for the most part is 0.1 millimeters a year. I'm happy. I'm like, yes, that's perfect.
Excellent. Next question, kind of a two-part question, I guess, kind of piggybacking off of the contact lenses. If you have a patient that's wearing RGPs, how long are they out of the lenses before you do the baseline topo? And then if RX changes as the patient gets older, are you altering the parameters, or do you do a washout and like restart the whole process?
Yeah. Okay. So the patient was previously fit with Ortho-K or wearing RGPs. The official answer is when you have stable topography. So you take a topography, and if you get the same topography again in serial, then your washout period would be done, is the official answer. And now what usually happens is that if they're doing orthokeratology, that can take, depending how long they've been wearing orthokeratology lenses, it can take longer, but usually a month is good-ish or less, but a month-ish. And then the second question was, do you wash out if you're going to redesign? I usually, unless I'm making big changes, usually they're just small tweaks, because my first lens, just to pat myself on the back a little bit, is not that bad. So yeah, I don't wash out. I would just kind of just redesign and just give the patient a new lens.
Great. Dr. Brill wants to know more about treehouse eyes and how that's affected your practice.
Oh yes, I love treehouse eyes. So with anything, if I were to, let's say I'm Tom Brady, I'm the best football player of all time, the GOAT. Does he have a quarterback coach? I think he does, and he has a coach, and so, and even Stephen, you've got coaches for stuff, to teach you how to do things, or set up even Wu University, so I joined Treehouse Eyes because we all still need a coach to help us, guide us, to help us kind of hold us to the fire, to get us to implement the programs that we want to implement, keep us accountable. And so that's why I'm in it, and I'd recommend it highly.
Great. Last question from Dr. Toe. If you get a new patient that's already in Ortho-K from another office, is it always best to wash them out, or can you try a lens over their existing treatment?
Yeah, if is the patient happy? If the patient's happy, then I would try to get the original lens design and try to just keep it going. I've definitely done that before. I had a patient. She was on my yearbook slide, Brooke Messer. She sent me a patient from Minnesota, and since we're friends, she sent me the parameters. I was like, and the patient was like, perfect. I just kept it going, But most of the time, I see at least a couple a month that are coming to me because they don't like the orthokeratology at the other office. So I get at least 2 signups a month of those. And so so most of the time I wash out.
Yeah. Great. Well, this concludes the formal CE portion of the event. And I just want to say thanks to Dr. Mai for this amazing presentation.